1 second, please. Oh, there we go. All right, I apologize. We're gonna present actually two cases. What I'd like to do is I'd like to present both cases back to back, and then what I'd like to do is go over the discussion. So we're going to start with, and then again, I want to emphasize that at any time, if you have any questions or anything, please ask. So the first case is case number 1. He's a 35-year-old African-American male. He has a history of HIV since 2002. He presented in July 2007 to a hospital in Orlando, Florida, with 1 month history of productive cough, fevers, and a 30-pound weight loss. A chest X-ray showed a mild perihilar and lower lung interstitial pneumonia, left hilar fullness. Okay, thank you. And what you can see here, and again, Marie, would you do me a favor if you would, thank you. What you can see here, I think you'd agree, is that the left hilar appears quite full, and he also has this perihilar fullness right here, infiltrate right here, and you can see on lateral but we would say the AP window is quite filled in right here. Dr. Sababa, do you agree with that? Yeah, he does. One of the nicest things about Dr. Sababa right now is he has a pastrami sandwich in his mouth, and that's one I purposely ask him at all times. So the AFC sputum smears were positive, and just to emphasize, they saw many AFC on smear, and that's really, as you'll see in a second, to really emphasize, this guy, despite having an X-ray that may not have been that, impressive, had a large burden of disease, it seems like, at least by smears. And subsequently, he's cultured with positive pan-susceptible TB. He started on 4th drug therapy. He was on INH, rifampin, and Samsung PVA on July 16th and stayed in the hospital until July 19th. And then on July 19th, he told the hospital that he had to leave immediately to go to Texas because he had a funeral of a family member. The patient was told to coordinate his care with the local health department as well as the Texas health department to assure that he would get his medications, but unfortunately he never did. And what is very concerning to us is, according to the patient, he was given some medications when he left the hospital, but ran out of them while he was away. And I know Dr. Sababa is going to ask me this. I'm going to say, no, they were not combination pills. They were individual medications, and obviously that's very, very important. The patient returned to Florida in late August and never saw treatment. However, he started to experience symptoms again, and he represented himself to another hospital in Orlando on September 11, 2007, so about 2 months after he originally presented. This is his chest X-ray, and I think you'd agree, you could really, again, see that he had a very, very prominent hilar fullness, and again, this perihilar infiltrate, and again, you could really see that hilar area was pretty enlarged and full. This is the X-rays comparing them from July to September. And again, I think you'd agree that you can really see that there may have been an enlargement in that left hilar fullness. Also on the right, I do want to emphasize, I think that, again, I always like to teach the fellows that there's some fullness here, too. And again, a lot of times we read X-rays with a little bit of a bias, that in some patients who may have been HIV negative, we may have let this go. But in an HIV positive, whenever you see the hilar being full, or what I like to say concave out, you always start to worry that there may be a little adenopathy there. So the patient was found to be AFP positive, again, numerous AFP again, subsequently culture positive TB, again, pan-susceptible. And these are the key points I'd like to point out. His CD4 count was 8. His CD4 percentage was 1%. His ratio was 0.02, very low, I think you'd agree. At that time, we didn't have a viral load from the other hospital. He was restarted on his 4 drugs, and given his previous history of non-adherence, the patient was court-ordered by the state to Holley Hospital. He had no other history, he had no other history of TB exposure, but he did have risk factors for being exposed to TB, which included that he was in jail, he's been in prison, but he denied any history of homelessness. He has a history of HIV since 2002. In the past, he'd been on sleep for 6 months, 2004. He also had a history of PCT, or pneumocystis cerevisiae pneumonia in the past. He denies alcohol abuse. He had a previous history of using cocaine 10 years ago. He denies IV drug abuse, and he denied any psilocybin exposure. Upon admission to AG Holley, he was on daily 4-drug therapy, which was continued with rifabutin, 300 milligrams a day, INH, ethambutol, PVA, B6, in addition to Bactrim and acyclovir. He clinically responded. He became afebrile with weight gain. He was smear negative on admission to AG Holley, but initially culture positive. And again, the repeat susceptibilities, this is back in September of 2007, was still pan-susceptible. He became and remained culture negative from October 9, 2007. This is his X-ray, and again, the techniques are clearly different, but this is an X-ray to AG Holley, and again, it's a little over-penetrated, but there may be some left hilar fullness there. His HIV viral load on admission was 4,800. His CD4 count was 15, 2%, and he had a ratio of 0.03. His HIV phenotype and genotype were pan-susceptible. MRI of his brain was negative. And when he was admitted to Holley, before we were about to start him on antiretroviral medications on December 3rd, which is approximately 2 months after coming to Holley, you can see his viral load was very low. It was 4,300, not bad, but I think that was because the CD4 count was so low at 26. Percentage 3%, ratio 0.04. On December 4th, we started him on Kaletra, which is lopinavir and ritonavir, and Truvada. And this was as part of a study that we were doing with A.G. Holley, the University of Miami, and what's that name of that place in Denver? Oh, right, National Jewish. And it was a study we had going on looking at drug levels between rifabutin and Kaletra. And the TB meds, as part of the protocol, was switched to Ionase 900 milligrams 3 times a week, rifabutin 150 milligrams 3 times a week. I want to emphasize this. First of all, it was intermittent therapy, 3 times a week therapy, which was the recommendations of, at the time. And also you notice that the recommendation was to use rifabutin at 150 milligrams, which was the concept of, because the ritonavir and lopinavir interfered with rifabutin, that you would lower the dose because it raised the levels of these drugs. And I'll explain in a couple of minutes why I'm explaining that, but his TB meds were switched to 3 times a week. And interestingly enough, approximately a month after starting the HIV meds, he started having what we would call an immune reconstitution syndrome. He had fevers, he had complaints of body aches, denied any abdominal pain, nausea, vomiting, and cough, and I'll explain why that's important in a second. His physical exam was a slightly enlarged liver, but it was really not that enlarged. The symptoms developed 29 days after starting anti-ret. His blood cultures, urine cultures, sputum cultures were all negative, again, because you can't just say it's immune reconstitution. You always want to rule out other etiologies. At the time, his white count was 3.8. His hemoglobin was 14.7, nothing terrible. The only thing that we saw on him is that, and this is interesting, that his liver enzymes had gone up slightly. His AST was 146, ALT 191. The fevers and the symptoms lasted about 8 days. He had a Tmax of 103, and then resolved without any other further interventions. And I do want to say we never imaged his abdomen because we never really felt he was that he was that sick. And the LFTs returned to normal, and he did well. This is his X-ray at the time, so it really, again, no real changes. Still with that left perihilar and right hilar fullness. And what happened is that we actually got back his drug levels, which I'll show you in a little while. And his rifabutin level actually was very, very low. His rifabutin level had to be increased to 300 milligrams 3 times a week. And oh, by the way, which I'll tell you about in a second, this data is about to be published. But one of the findings of the study is that the recommended doses right now for rifabutin are probably too low for Kaletra. And that was something we found, and it's going through right now publication. But what happens is HIV studies, as you see, when all this happened, his CD4 count went up to 56. His viral load went down, not undetectable, but pretty well. And interestingly enough, something we found in most of our patients that we always think is important is he converted his CST, which now he was positive, which again is a sign, in my opinion, that not only is the immune reconstitution in some way may be related to a restoration, as they say, of his T cells, and that's why it's called the immune reconstitution, because I think that you can see his T cell function return. So what happened is, I just want to show you this real briefly. What you can see here, this was his drug level when he was on the when we started him on the this is when he was on 300 milligrams a day of rifabutin, right, and without the lopinavir. And as you can see, the expected level is 0.3 to 0.9. So you can see he's well below, even when he's on 300 milligrams pre-lopinavir, he's well below, he's 50% below the lower limits of normal. You can see when we started him on the 150 milligrams of lopinavir, while I think you'd agree the levels were similar to the 300, so the lopinavir definitely does boost the rifabutin because we have the dose, they still were significantly lower than they should be. And then again, even when we increased it to 300 milligrams retrospectively, you can see he still never achieved where he was the expected levels of rifabutin. These are his lopinavir levels real quickly. I don't want to, but you can see his lopinavir levels, on the other hand, were normal no matter what we did. So they were within the 5 to 14 peak, so he was okay. Clinically, he did well. He gained over 89 pounds during admission. He completed 6 months of TB therapy on March 14th. He was discharged on Calitra, Truvada, Acyclovir, and Bactrim, and follow-up appointments were arranged with the local health department. Once the patient left the H.E. Holley Hospital, he stopped taking his antiretrovirals. Dr. Sabaro, yes, you were right. And then in June of 2008, he was arrested and he was placed in jail. And soon after arriving in jail, he started complaining of non-productive cough and fever. He was transferred to a hospital again now in Orlando, where a chest X-ray was allegedly abnormal. The reason I say alleged is we don't have the reports or the film. And then on June 13th, he underwent a bronchoscopy, which was smear negative, and he also had blood cultures performed at the time. He death-possessed. They gave him some antibiotics. We don't know what antibiotics he was given in particular. We don't know if he was given a quinolone or not. And he was discharged and returned to jail. And then on June 19th, once he was in jail again, he started developing nausea and vomiting and diarrhea right up to quadrant pain. And he had a headache and a fever to 104. He was transferred to another hospital, and as part of the workup, he was found to have retroperitoneal lymphadenopathy on the CT of the abdomen. And this is the CT of the abdomen. As you can see here, these are the retroperitoneal lymph nodes. We had a bulky adenopathy here. And what they did here, as you can see, is they turned them over. They stuck a needle into these lymph nodes, right? So here's the needle going in. And the CT-guided biopsy of these lymph nodes were numerous AST positive, nucleic acid amplification positive, and the past showed scant fibrous tissue, clotted blood, no lymph, it wasn't cancer or anything. And the Heinz test, because we were very concerned that this may be resistance, the Heinz test, which is, as you guys know, and I want to put a quick shout out here, there's a new test being offered in the state of Florida, and not only in the state of Florida, but also in the southeast, in the southeast region for the SNCC. If any of you guys have a case where you would like to, that you think it may be appropriate to get the Heinz test, if you give us a call, we'd be able to arrange that for you at no charge, thanks to a grant through the SNCC and the Virginia Foundation for TB, which funded it. And as you know, the Heinz test is a new molecular test that within 1 day, we can not only say that it's TB, but we also can say if it's INH or rifampin resistant with a certain amount of certainty. And again, this is now available to us. And in this case, the Heinz test of the lymph node biopsy revealed no mutation. So good. It looks like he just had a relapse or a reinfection of TB. We'll talk about it in a second. But here's, and subsequently the lymph node cultures actually confirmed that he was pan-susceptible. So he was placed back on the 4 meds. And this is just a real quick, I meant like kind of an endorsement of when the Heinz test is useful. Think about it. In this case, he may have had to be on immunoglobulin. I think all of us would have agreed that we should have started him on 2 extra medications if he had any resistance, because we weren't. So what happens on July 1st, they start him on 4 drugs, and they also do a further workup. They do an MRI of his brain, which is negative. They do a lumbar puncture, is negative. They do a CT of his chest that shows a small pericardial effusion, but otherwise negative, right? And on the time this is all happening, you can see his viral load is back up to 6,500. His CD4 count is 4. He's back to where he was before. These are his chest X-rays, and I want to emphasize. These are his CAT scans, and I want to emphasize. I know that I put them up here, but why I'm putting them up here? They're negative. They look really good, right? Nothing there, right? And he has even some here's CTs of his mediastinal views, and maybe he has a little prehilar, precarinal lymph nodes, but nothing really significant, So here's the story. While he's at the other hospital, we get back on July 1st, like a day after this whole workup is done, that the cultures that were done from the blood and the bronchoscopy at the other hospital are now being reported to be positive. And when we send those specimens up to the state lab for Heinz testing, the two sets of blood cultures that were positive, great, the Heinz tests are negative. But here's the key point. The bronch washing and subsequently the sputum that we collect now we're showing rifampin monoresistance. So what's interesting, and I want to emphasize 2 cultures, because, the first thing, I saw Dr. Sabaro, he almost choked on the pastrami sandwich. We don't want that happening. But yes, one of the first things we'd be worried about, maybe this is a mistake, But it's 2 cultures, and I'll show you the Sligos later that show it all matches, But interestingly enough, the Heinz test quickly tells us it's rifampin resistant, and I will tell you, subsequent susceptibilities confirm rifampin resistance. So this is an interesting case in the sense that he has pan-susceptible disease in his blood, in his lymph nodes, and in his sputum. He's showing resistance despite, I think you'd agree, a pretty normal X-ray. And what's interesting, when we go back later and we solidotype them all, they all match. So this is a case of acquired rifampin monoresistance, which we'll talk about in a second, And once we get back those results, we start them on moxifloxacin and amikacin, And as we said, the typing confirms that all of these match, and not only do they all match, but they match his original strain in September of 2007. And I want to emphasize one last part. The original September 2007 strain shows no mutation. So this is not somebody who had this before. So this is a rifampin monoresistant, and we'll talk about why he may have gotten it in a second. So given the patient's prior history of non-adherence, he's back here at AG Holley, spending some time with us. I want to just for 1 second, I want to just stop and say I'd like to present the second case too, because I think they have a lot in common, and I'd like to kind of talk to you about this whole issue. But is there any questions on the phone, or is there any questions here before I start, and then we can go to the second case? Okay, if it's okay with everybody, what I'll then do is let me go to the second case, and then we'll start going to questions in a second. So the second case is a 51-year-old white female presented to an Orange County hospital ER on June 20. Orange County, that's here in Florida. We steal all the good county names, so this is not California, so we like the name. So so the patient is she goes to an Orange County hospital to the ER on June 25th, 2007, with a 2 to 3 week history of cough and fever. She had a long history of substance abuse, crack cocaine, and alcohol. And upon her arrival to the ER, she was found to be cachectic, febrile, hypoxic, hypotensive. She's on vasopressors, she said. They do a chest X-ray that shows a right middle lobe infiltrate with a right pleural effusion. A CAT scan shows extensive right infiltrates with a small right upper lobe cavity and moderate right pleural effusion. This is the X-ray that we got from the hospital, and you can see, I think you'd agree, that she has this right middle lobe. Again, you see the silhouette. You don't see the right heart border with what looks like the cavity here and a left pleural effusion. Do you agree with that, Dr. Barbaro? I don't want to. Okay. And this is the CAT scans we got, and again, I think you'd agree. It confirms that she actually had bilateral pleural effusion, right? And you can see this really, really extensive, socked in, what looks like here, involvement of the right upper lobe. Here's, again, the right upper lobe with the cavity and also the right middle lobe here. So it's more extensive than the X-ray, I think, initially showed, and it's really consolidated with air bronchograms, pleural effusions. This is just to show, again, that she also, one of the points I want to make is she also had a little adenopathy here, but again, horrible. They did sputum smears on them. They were positive, MTD positive, substance found to be pan-susceptible, and a 4-drug regimen was started on June 26th. They did a thoracentesis. There's 1,500 white cells, 90% lymph. The glucose is not that terrible. Protein's low, so it looks more like, to be honest with you, more like a transudate than anything else. The gram stains are negative. AFB smears are negative, but cultures grow out TB, and they feel that this is, the cultures do not grow out TB, culture negative TB, and they feel this is a reactive TB effusion. At the same time, though, they find out that she's HIV positive. Her hospital cost is also significant for a lower GI bleed with bloody diarrhea, a drop in hemoglobin to 6.3, and the exact etiology of the GI bleed was never determined, and we'll talk about that later. She's discharged from the hospital directly on observed therapy on July 12th, and they made arrangements for her to live at what we call the Orange County TB shelter. Dr. Sababa alluded to this, that you need places sometimes to place patients who have problems with homeless. And in the state of Florida, not only do we have a place like AG Holley, but we actually have in Orlando a TB shelter. That's actually a house that was donated, interestingly enough, by the banks of Orlando, and they actually was done through a collaborative effort between the hospitals of Orlando and the banks, because it was worth the while of the hospitals to donate money to this cause so that they got patients out quicker. So it was a win-win. So they got a tax exemption, and they have this TB shelter that's being run by the Homeless Coalition of Orange County. So that's where she went, and on daily medications until August 26, 2007, at which time they switched to the 3 times a week. But again, I want to emphasize something very important. Here's somebody who was on daily regimen for 2 months, right, and then gets switched over to 3 times a week. And during that phase, she was on TB meds. She intermittently complained of a pruritic rash, and she was adherent to therapy except for 1 dose. But the staff at the health department said, look, she was really difficult. She had this rash. She kept really being very, very resistant to taking the meds. Finally get her to take it sometimes. So again, that whole issue I was bringing up before about adherence. And in both cases, we have this very early on, I want to point this out, questions of adherence. When, if I'm correct, Dr. Barbaro, more bugs, more drugs, right? if I'm correct, the most important time to make sure that your adherence to therapy is early on when you have the most bugs, when you have the highest chances of maybe getting resistance, if I'm correct, right? If you don't, in both cases have that being that's there, and that's something that we'll talk about later we found when we went back and looked at all of our cases. So she presented again to the same hospital back in Orange County on December 23rd. Now she's complaining of right back pain, flank pain, fever, chills, and weight loss. They do an abdominal CT. It shows the possibility of obstruction and inflammation in the right lower ureter. She's diagnosed with right hydronephrosis. It seems to be due to lower ureter scarring from TB. And the urine analysis, again, really had a lot of white cells, but they never sent some urine for AFB. Why am I pointing this out? Because in both cases, something we'll talk about, there was evidence of extrapulmonary disease, which I think also may be playing a role. So what happens is these are CTs, and you can see that there's a right hydronephrosis here on the right kidney. You can see the ureter is all obstructed. Again, you can see the hydronephrosis ureter here. You can see that prior right middle lobe or right upper lobe infiltrate has really remarkably gotten better, and then you can see here that on CAT scan, remember that tremendous consolidation, this is all that's left of it. So she really has had a very nice response from a TB point of view in the lung. So they placed a nephrostomy tube on her. It's placed successfully for decompression. It was later removed. She also had placement of an indwelling stent. She started on TB meds on December 24th. Again, she's complaining of intermittent itching. And what happened is because she kept having so much difficulty and she was missing some appointments, they committed her to H.E. Holley on January 7, 2008. She has no history of TB exposure, but again, she gives this risk factors of being homeless, being in jail but never imprisoned, history of alcohol use, 16-pack of cigarette smoking history. She works in construction, never did any cement work. She's having problems with cocaine and marijuana, denied any IV drug abuse, history of a Bactrim allergy, but the records show that she'd been on Bactrim in the past. As we stated, she was diagnosed with HIV in June of 2007. She had never been on antidepressants. She also gives a history of bipolar disorder, and she's been on Paxil in the past. So upon admission to H.E. Holley, she appears chronically ill. She only weighed 98 pounds. This is her X-ray. So Holley, again, I apologize. This is our scanner. As you see, we're having a little bit of our problem here. But she just has this right, what looks like, right upper lobe infiltration. She started on ionate trifidin, TB, and a hand pill. And 2 days after starting the TB meds, she started having a pruritus macular papular rash. Thought to be consistent with a drug reaction, her eosinophils are 15%. We stop all of her meds except for antihistamines, but the rash continues. We put her on, and she also has eosinophilia. We put her on some steroids. And then we also realized there may be an issue with contact dermatitis. They stop all her skin products. And we also changed her laundry detergent. She seems to have gotten better. She gets better. The eosinophils resolved. We really never found the clear etiology. And on January 13, 2008, we introduced each of the medications one by one with occasional complaints of pruritus, but no rash was appreciated. And she's placed on a regimen of Rifabutin, TBA, and ethambutol. She gained 21 pounds during the hospital stay. She's smearing culture negatives since January 8th. As you can see, HIV viral loads were 185,000. C function was 14. 2% ratio was 0.02. She refused any HIV treatment due to fears of drug reactions.
Excuse me, if you would please mute all lines by pressing star 6 and unmute for star 7.
Initially with 4 drugs for 2 months, and then we switched to ionate rifampicin 3 times a week for 1 month. So she received about 4 months of therapy prior to coming to H.E. Holley. And as you can see, the vast majority of it was on daily therapy. And even when it wasn't daily, it was on 3 times a week. She was smear culture negative during the hospitalization. We treated her with 4 drugs for 4 months to complete at least 6 months of therapy. We started back on her therapy on June 15th, and she complained that she completed her therapy on June 17th. The reason there was some prolongation, she had some problems with the stent that was placed, and we had to remove it. So she stayed here a little extra. This is her X-ray upon discharge, and you can see she really didn't have much left. Just some residual, changes, which really were about the same. So after the patient's discharge, the culture collected while the patient was at H.E. Holley. So let me emphasize this. So on June 4th, while she was here, and one of the policies we have at H.E. Holley was we collect sputums on patients weekly. Why do we do that? For research purposes, So on June 4th, we collect the specimen, and remember, she leaves on June 17th. She's smear negative, everything looks good, but after she leaves, on August 9th, we get back that smear, that culture that we collected was positive for TB, and her susceptibilities were pending. And when we did the Heinz test on it again, we found now there was an RPOB gene mutation, and subsequently the susceptibility confirmed that she was rifampin and rifabutin resistant. She was what we found out later is that we located her, and unfortunately, where was she? She ended up in jail. And interestingly enough, unfortunately, when she left here, she was actually discharged to jail. And the reason was she had pending charges on her. We found her back in jail on August 8th. She was started back on ionate rifabutin, PZA, levofloxacin, and streptomycin. They did a chest X-ray on June 25th and repeat X-rays on August 14th, and just pretty much just showed the same scarring. They really didn't change over time. 2 weeks after signing the TB med, she started refusing the meds due to development of rash, and unfortunately, she was sent to AG Holley on September 23rd after she completed her jail. And when we went back and did the spligotyping again, the 2007 matched the June of 2008. So this is a true case. And again, when we went back and looked at the when we went back and looked at the RPOB gene mutations originally, they did not exist. So it's an acquired case. This is her admission films when she came to us, and I think you can see here that that hilar infiltrate looks a little fuller now than it did when she left, and you can compare it here. So it looks like there is some progression there. So what I wanted to talk about and I can stop. Let me stop here to have any questions asked about these cases, and then what I'd like to talk to you about is acquired rifampin resistance and what's happening. So if I can stop for a second, I know I presented these cases relatively quick. I wanted to get through them to illustrate a point, but are there any questions about the cases or anything else that I may have messed up? And I do that a lot.
If you would like to ask a question, please press *7 to unmute your line.
Okay. All right, Jesus, you have a question, right? Hold on 1 second. Let me just get the microphone.
Yeah, this is more of a comment than a question. But this particular patient is noted to had a history of bipolar disorder, and we not unusually get patients with that diagnosis. It seems to be a diagnosis with less stigma in the out in the community. So a lot of people they walk around, they say they're bipolar. We didn't see her as bipolar, and she definitely has a personality disorder. In dealing with her, you can tell. I mean, she sets you off, creates a lot of countertransference, like we were talking about earlier, and very difficult. And these are the patients that sometimes become very difficult with adherence. So just a little, she got like antisocial and borderline features. She got mixed personality disorder, which is definitely creates a lot of complications in dealing with her, especially those that deal directly with her on a day-to-day basis.
Actually, and I'll get you, Mark, one thing, but as an aside, actually, the problem we're having with her right now is she's absolutely, and this is an aside from the story, but she's absolutely refused all medications, and she now wants, she's now wishing to die. And she's been assessed by Jesus and our staff, and we unfortunately feel that she's now unable to make medical decisions, and now we're going into healthcare surrogates, which is a whole other area. These cases can be really difficult. Mark, do you have a question?
That was my question, David. What rights do you have to insist on drug levels and things like that?
I got to be honest with you. If in hindsight, and we're going to talk about that right now, it is so rare for somebody to refuse. The patients come to Holley, as much as you may get this really bad picture of the number. It's not true. I mean, most of them that are here, the vast majority are really cooperative. Do you agree with that, Jesus and the rest of the staff? They're very cooperative. They allowed. If we felt that there was really a reason we had to push, I think we would have pushed her. But the real reason we do these a lot of the times is for research purposes, And in this case, we didn't really have a clinical reason to push. Now, you're going to hear me make a case that maybe from here on in, I think we should have a clinical reason to push. And I think that's what the case I'd like to make today during this presentation. And, and just as an aside, this presentation was actually presented to the CDC 2 weeks ago at what they call we have this new meeting that's called the Expert TB Network meeting, something like that, where the group of us around the country meet and talk about interesting cases or issues. And I presented it to them, and I'm now presenting it to you because I think there's some implications to how we do TB and what this means. But at the time, Mark, we try not to infringe on people's rights unless we have to. And if we had a clinical reason, I think we would have pushed. Hindsight, maybe it would have been a smart move. it's like that. That's how you learn, you know. I'm sorry, was there another question? No. Any questions up there, Donna? Oh, no, good. So what I'd like to do is go into a discussion. Again, I really want to make this open, and you'll see there's actually going to be questions in this, and please help us with this. But I'm sure all of you looking at this are aware of this. This was the MMWR that came out on March 15, 2002. And this was the message about a notice to read about acquired rifampin resistance in TB in persons with advanced HIV disease being treated for active TB and intermittent rifampin-based regimens. And what this was based on was what's called the Tuberculosis Trial Consortium Study 23. And what it was all about was that since the mid-1990s, we started recommending the use of rifabutin when we were using other HIV medications for patients who were HIV positive. There really had never been a study to show that was rifabutin working. So the whole idea behind this study was to evaluate rifabutin in HIV-positive individuals. And it was a single-arm trial of twice-weekly based rifabutin for the treatment of HIV. And what happened was the TBTC's Data and Safety Monitoring Board, which I have to now say, I just realized as a disclaimer, I am now part of that. I wasn't at the time. So as a disclaimer, I may have some interest in that. And it's a great board. and what I want to emphasize was the TBTC, and these are aside, what they do is amazing. And the reason it's amazing is that it gives us some understandings of what's going on, and it's true double-blinded research that's is so needed in the United States. And I can't shout out enough how important the TBTC is. But the bottom line came down to the TBTC Data Safety Monitoring Board actually advised the CDC to suspend enrollment in this study because what happened was of 160 patients or 156 patients that were involved in the trial, as you can see, 96% of them got better. They were cured with good follow-up cure. Dr. Sabarbaro, I think that's a good number, right? 96% would be accepted, right? There was nothing wrong with it. Rifabutin works. The problem was this. Of those 156, 5 of those patients, when they failed, they just didn't fail, but they failed with acquired rifampin resistance. And so what they stated was, although the rate of treatment failure relapse in the study had been low, right, the problem was they had acquired rifampin resistance, and this became a major issue. And when they went to look at it, they looked at it initially, and they found that the common features in these patients is all had a very low CD4 count, less than 60 at TB diagnosis, and all had received twice-weekly therapy in 4 to 5 during the intensive phase, during the first 2 months of therapy, and all 5 received twice-weekly therapy in the continuation phase. I want to emphasize this point. Notice, right, 4 of the 5, not all 5, right, got the intermittent. There was one who was daily. And because of this, in 2002, the CDC wanted to report these findings and make a recommendation. They said, a relationship appears to exist between the frequency of dosing and the risk of acquired rifampin resistance. And support for the statement is they stated in an earlier study of treatment of HIV-TB using once-weekly rifampicin plus INH, acquired rifampin resistance was common. And they went on to say acquired rifampin resistance was also occurring in a previous study of HIV-TB treated with twice-weekly. Plus, in all of these studies, patients with acquired rifampin resistance had very low CD4 counts at the time of their diagnosis. And their recommendation was this, and I want to emphasize these points. It's taken directly out. It says, the consistency of these findings suggests that once or twice-weekly therapy, including INH and rifamycin, increases the risk of acquired rifamycin resistance among TB patients with advanced HIV. And that's an exact quote. And it says additional data are needed to clarify these issues, which we all agree, but until such data becomes available, the CDC recommends that persons with HIV-TB and a CD4 count less than 100 not be treated with highly intermittent therapy, once or twice weekly. These patients should receive daily therapy during the intensive phase and daily or 3 times dosing a week during the continuation phase. In this group of patients, CDC recommends directly observed therapy for both daily and 3 doses a week regimen. Dr. Barbaro, what about that statement bothers you? And if you want to comment, or I'm not trying to put you on the spot, so please. So give him a mic. So let's hear from Dr. Barbaro here. And I didn't tell you that we were going to. Yeah, Karen, where the hell are you? All right. Heck, where the heck are you? Problems with thanks. So, Dr. Farber, what concerns you, or what, and when I say, let me generalize the statement, not about the science because you don't have it, but from a DOT standpoint, if we switch, what are your concerns? Or what stresses do you think may be placed? And so go ahead and comment, please.
Well, first of all, I think your two cases point out what all of us really know, that there is no sterilizing regimen. You can get the numbers of bugs down, but when the immune system goes, there is no sterilizing regimen unless you want to do it for 5, 10, 15 years. Because as long as the bug is dormant, you're not going to be able to kill it. So that eliminates one issue. Then you look up here and you say, okay, why would 3 times a week be better than twice a week?
And so let's go.
And I believe that it is.
And let's go over the rationale, and let's go over what the implications are. So the rationale that they had was a very interesting rationale, and that's where we're going to go. But the rationale was this. The half-life of INH, right, is measured in hours. And, Jerry, 1 to 3 hours. Is that correct? Okay.
Right.
The half-life of rifabutin is measured in hours. And when we talk hours, we're talking hours. And I don't want to get into debates of this because you see all different numbers. But, Jerry, the half-life of rifabutin is, what is it?
About 14.
I'm sorry?
45.
About
45 hours.
So about 45 hours. So
About a day and a half.
What is exactly? So what the rationale was that what was happening is after 1 day, because the half-life of INH is so low, the INH was gone, and all that was left was rifabutin.
Yeah, single drug therapy all the way through this.
So that was the concern they had. Here's my concern. My concern was a little different. Now, I'm not saying my concern was this. Now, as a TB health officer or controller, right, I have a limited number of TB DOT workers as it is. And now what you're asking me to do is to put a DOT worker that I used to only use daily for 2 weeks, now on this case daily for at least 2 months, if not longer. So I was looking at an increase of my workload by at least 50%. Now, if it means rifampin monoresistance, would we do it? Yes. But the question is, we've got to make sure, as we'll talk about, that that's really the issue. And I have no problems with the recommendation, but I guess the question, as we'll talk about in a little while, is we've got to make sure. So what this then changed our recommendations, and in the state of Florida, I can tell you when we looked at it, almost everybody is using intermittent therapy. But I want to ask everybody out there, and here's our toy, guys, to help me out. You see those little buttons on the left there? So for all you guys, the guys in the audience, they can't answer, but the guys on the web, you can really help me out. So for HIV-infected persons with TB disease, do you or your program utilize daily regimens for the entire treatment, daily regimens for 2 weeks, then twice weekly therapy, daily regimens for 2 weeks, then thrice a week therapy, daily regimens for 2 months, then twice a week therapy, or daily regimens for 2 months, then thrice a week therapy? So thanks, guys, you're doing great. Keep voting. We're in an election year here, so we're trying to, it's pretty cool technology, as you can see. But what you're looking at is, what you can see here is that there are, it looks like out of 7 people, please vote, guys. You're doing great. Thank you so much for voting. And you can see, I want to emphasize, nobody knows who you are, I promise, okay? So it's totally anonymous, except for Moss. If you're out there, we know you. But no, I don't know if he's out there. But the bottom line is, of 8 people who are responding right now, you can see that almost, and I do agree, I think this is Florida, we're either using daily regimens for the entire regimen or daily regimens for 2 months and then thrice a week. We're significantly impacting our DOT and the resources we have. Thank you so much for voting, guys. I can't thank you enough. So, I'm sorry, okay, so apologize. So, wait, we got question 2. Okay, sorry about that. So for HIV, so you did so good the first time, let's see you do it again. So for HIV-infected persons with TB disease, do you or your program utilize rifampin for the whole course, rifabutin for the whole course, or it depends if antiretrovirals are being used? And while you guys are answering that, I didn't give the audience here. So you guys who work in the health departments and stuff like that, we're, for the most part, we don't use twice-a-week therapy anymore, for the most part, right? I mean, I don't think we've seen that for a little while, and everybody's shaking their heads. For the most part, in HIV positives, we pretty much either go for daily the entire or daily with 3 times. So it's definitely, I think, impacted our needs. And thanks again, guys. I love that it's working. Thanks for answering. And I think the same thing is that I think most of us have also adopted that we're really using either rifampin or rifabutin or whatever, depending on which antiretroviral. So as you can see, these recommendations have really impacted the way we're doing. And I agree. Here in Florida, this is exactly how we would answer it. I think we do both. Here at AG Holley, I got to be honest with you, we almost pretty much use rifabutin almost all the time. But in the community, I think it goes both ways, and I think this really reflects not only what's happening in Florida, but it's cool to see it as reflecting what's happening around the United States. And so, again, thank you guys for voting. We really appreciate it. I think it's very educational. So I want to just go over, I apologize, I kind of messed this up. Okay, now I'm good. So I want to read this exactly what it says. This is from TBTC, and this is actually 3 years later when they published the actual data, or 4 years later. I want to emphasize a very important point. Anybody who's done research, anybody who's written, this is not uncommon. So I want to emphasize these are not criticisms. The people who are involved in this, Bill, from college, unbelievable people. I mean, they've taught us more, so these are not criticism, but this is the reality. A lot of times you're forced to make a decision, and then later on you look at the data. So when the article actually came out 4 years later, it says, among patients with HIV-related TB treated with directly observed therapy, there are two consistent associations in this and previous studies with the occurrence of acquired rifampin resistance. The presence of severe immunodeficiency, CD4 counts less than 100, and the use of once or twice therapy. Acquired rifampin resistance has been reported with twice-weekly rifabutin plus INH, 4.7 in the present study, and with twice-weekly rifampin plus INH, as you can see, percentages. In contrast, the rate of acquired rifampin resistance among HIV-infected persons treated with daily rifampin-based or rifabutin has been very low. But I want to show you the data. The interpretation of these data from different clinical trials and observation cohorts is difficult. Boy, don't you wish that they wrote that in the Cochrane study, right? We conclude there is a risk of acquired rifampin resistance with rifabutin or rifampin when given twice weekly, but whether the risk is higher with one of these is not clear. But I want to show you something, and unfortunately, I realize here, I want to show you a couple of things. When you look at the actual numbers, so it says right here, use of twice-weekly therapy during the intensive phase, it never reached statistical significance. Never reached. The only things that reached statistical significance was a low CD4 count and use of antiretroviral therapy during the first 2 months. So this was a feeling. Now, I'm not saying it's not right, but it was a feeling, right? So they quoted one of the studies, and they quoted the New York City study, and said no person who was treated with rifabutin-based regimen alone and one person who was treated with a rifabutin and rifampin had ARR. This finding differs from the findings of previous studies in which intermittent dosing of rifabutin or previous studies where rifabutin was suspected to be the probable cause. The difference may be the result of the fact that none of the patients in the present study began receiving intermittent dosing with rifabutin. Again, it was a speculation. Second, intermittent rifampin therapy significantly increased the risk of ARR only when intermittent dosing was begun in the intensive phase. But again, I want to show you something very important. When you go back to the original studies, right, here it is. They acquired rifampin resistance, and they were on daily rifampin the whole time, or daily rifabutin. It clearly happened. And you'll see what I'm saying is that the problem is that intermittency, while people are talking about it, especially twice weekly, is not so clear to be the real reason. So the question is, are we going with a leap of faith? Although the use of twice-weekly therapy this is straight from Bill's article. Again, I want to emphasize, great job. Although use of twice-weekly therapy was associated with acquired rifampin resistance among patients with low baseline CD4 counts, our study did not include a group of randomized to more frequent dosing. They never did a control or another arm. It says, evaluating the relationship between dosing frequency and the success of treatment of HIV-related TB should be a high priority for future randomized studies. Agreed. And that's going to be my question. So since we implemented these new guidelines, did things change? You would expect that if we did go ahead and we changed the guidelines, we would see a reduction. And here's the thing, no studies have been performed to show it. So we're now, at this very moment, allocating a lot of resources to DOT to do intermittently and daily without any proof. And we don't know if it works. So just to go over, it says, among patients in this trial who enrolled in a pharmacokinetic sub-study, and this is where we're going to go, and not a shout-out to Chuck, Pelican out of National Jewish, but he's taught us a lot. We're going to go over what they did. What's interesting about the TBTC 23 is they actually did drug levels on many of these patients. The only problem with the study, I have to be honest with you, they weren't necessarily done prospectively. meaning what they did after they acquired rifampin resistance, they went back to some of these patients and then did levels later to see what they did. So it's not a perfect study, but it's still as close as we had. It says among patients in this trial who enrolled in a pharmacokinetic sub-study, patients with low concentration of rifabutin were at increased risk of acquired rifampin resistance, even after adjusting for CD4 count. Thus, it appears that 3 factors are closely associated with acquired rifampin resistance: severe immunodeficiency, highly intermittent dosing, and low concentration. So they added the third part now. And it says these associations suggest in the relative absence of immune control. Wow, Dr. Sabarbaro, it sounds like you taught this guy. You taught both of these guys. Listen to this. Low concentration of rifamycin near the end of the prolonged dosing interval allow mycobacterial replication. Like Dr. Sabarbaro said, that in the low CD4, one of the problems may be is that we're not getting the sterilizing effect that we need. So what are the things? The 2002 recommendations mainly recommended changes focused on intermittent dosing, and no other further explanations were made for why does a low CD4 count cause this thing. It doesn't make sense, So if you look at this, in summary, they wanted to say, in TBTC, in summary, our study offers strong evidence that an important factor in the pathogenesis of the acquired rifampin resistance is abnormal pharmacokinetics of the drugs used to treat TB. The relationship between drug pharmacokinetics and acquired rifampin resistance was strongest for those who had a low rifabutin area under the curve. But data also suggested a low INH. Additional clinical trials are required before these results can be translated. And one of the things I want to show you, if you look in the study of TBTC, these black circles, these were the patients who acquired rifampin resistance. And just to orient you, this was the rifabutin levels, and these were the INH levels. And you can see those that had the lowest concentration tended to acquire the rifampin resistance. But I also want to show you something else. There's a lot of people in this curve here, right, that didn't acquire rifampin resistance. The difference is these patients' CD4 counts as a whole tended not to be as low. So it's not just simply low levels. So question number 3, if I may, for all you guys out there is, are you using drug levels in patients with HIV and active TB? So to ask while we're waiting, and thank you for doing this, but how many of you guys in the audience, is anybody using routine drug levels for HIV and people are shaking their heads? No, and we don't use it that. And as you can see here, you see people that are, most people are saying rarely, and it is not the standard of care for using in these cases. You see some people are actually saying sometimes, always, but it's not something that we're doing routinely. And I think that really does reflect what's going on. And again, guys out there, thank you very, very much for answering the questions. We really, really appreciate it. What I want to do let me finish the part, and then we'll go to questions if that's okay. We'll go to questions after. Okay, so what we wanted to do is when all these studies came out, what we did in Florida is we went and we looked at how many acquired rifampin resistance cases we had, and actually, let me tell you, the first study we did, and this was what we did with Massa, we looked in 1996 and 1997 and looked at all cases of relapse, no matter what, in Florida, and we found that the bottom line came down to recurrence of TB was not statistically associated with drug levels, but a high percentage of the lower than expected. And I said 60% had lower than expected levels of INH or rifampin, which raises the concern that expected drug levels derived from healthy volunteers may not represent. Meaning, I just want to remind everybody how we did these drug levels, right? The way that the expected levels came back, notice we never call these therapeutic levels. A therapeutic level actually means that you actually know how much drug you need in the blood to actually kill. And by traditional bacteriology, Dr. Barbaro and I know, isn't this weird? 2 pulmonologists talking about bacteriology and ID. We want to shoot ourselves right now, right?
Absolutely. All the ID guys want to take over.
Exactly. But traditionally, right, what we want to do is be at least we want our drug levels to be at least 4 to 16 times above the quote-unquote MIC.
Yes.
What's the problem with TB? We don't even know what the MIC of TB is. We don't even do that. We do critical concentrations, right, which is a whole other level, right, a whole other lecture, right? But the bottom line comes down to the way they came up with these levels is they knew, and I love listening to Chuck Pellerin tell these stories because he's so knowledgeable and he can teach us. And again, shout out to National Jewish for all the influence they have over me. But the bottom line came down to is this: is that the idea was that we knew 300 milligrams of INH cured most people. We knew 600 milligrams of rifampin cured most people. So what they did is they took a number of healthy volunteers, they gave them INH and rifampin, and they did their drug level, and that's how they came up with the expected level. But the problem is, I think you'd agree, Dr. Barber, one of my concerns has always been that normal, healthy volunteers usually don't get tuberculosis. Don't you agree? I've never treated a normal, healthy volunteer with TB. I don't know,
They're rare.
They're rare, yeah. So the problem comes down to is that, are these quote-unquote expected levels that we do, are they really true? And the question is, others, how low do you got to go? How low do the levels have to be before you get resistant, And when we looked at our levels, we found that all 10 patients that relapsed and who developed resistance, what the number one thing we found was non-adherence. So I want to emphasize the point that, I do think there's an emphasis of non-adherence, especially early on, that is an issue that I don't think we address nearly much. As a matter of fact, one of my frustrations when you go over non-adherence, so Dr. Sababa, when you look at studies of non-adherence, how do they define non-adherence? Is there a routine and how do you define non-adherence?
Every one of those studies is different. You know that. Sometimes it's drug level, sometimes it's observation, sometimes they actually believe what the patient does.
And what is the level? What always strikes me is this. What's the level? When you go from study to study, some studies will not consider you non-adherent until you miss 25% of your doses.
Right.
Others, the bottom line is, especially if you have somebody with a low CD4 count, which I love what you pointed out, and we'll talk about that later, it may be critical. Like you said before, one of the things that shocked some people was about the 15 minutes, and, matter of fact, somebody wanted before, which we got to get back to. Where's that documentation?
Anybody wants to write me a Denver email, I'll send them the citation. It came out of the CDC.
Right. But, the whole question is also the same thing, which is what level of non-adherence do you have to, it is maybe possible that if you miss one or two drugs early on, or you take one drug without the other early on, that may be enough to create the pressure that's needed to cause resistance, especially in somebody who has no immune system.
Remember, resistance is selection. You can't induce it. It's selection of the bag.
So, what we started asking ourselves here in Florida is, what was so special about a low CD4 count? Is it that, a lot of people believe, as Chuck will always tell you, a lot of people believe that maybe patients with low CD4 counts just malabsorb, but there really is no good reason other than there are some studies, if I'm correct, Jerry Jean, about what happens to G proteins in the stomach, right, in the intestines as your CD4, and especially as you get malnutrition. And also, obviously, it's clear that, when you have atrophy of the villi, there may be. But most studies, and again, I know if Chuck's out there, he'll yell at me and many, but most studies that look at lower than expected TB drug levels do not correlate very well with other classic markers for malabsorption. Meaning when you do these xylose tests, it's not a classic malabsorption. It's not like they're having watery diarrhea and fat loss. Do you agree with that, Dr. Sabaro? And there's no way to predict it. But the other things we started looking at that I think were very, very important, and I want to talk to you about this, Dr. Sabaro, is one is what we thought was important about low CD4 count, because almost in every case I'm going to show you in a second, almost every one of them had extrapulmonary disease. And so we thought that the low CD4 count in some ways may have been the low CD4 count creates or increases your risk of having extrapulmonary disease. And it's not just typical extrapulmonary disease, but an extrapulmonary disease in an HIV positive is very different than extrapulmonary disease in an HIV negative. So while I'm here, I'm gonna bother you, okay? So in your career, of all the TB tests that you did on thoracentesis that turned out to be TB, or you thought was TB, right? In HIV negatives, what percentage of them turn out to be AFP positive?
Good grief.
Would you say a lot, a little?
Little.
I'm sorry, would you say 10 to 30%? Would that be a good number?
I probably misdiagnosed so many of them, but 10 to 30% max.
Right. Now with HIV positive, it's a different ballgame. It's not. Now I'm going to talk to you on, but if you, and I know but as a pulmonary fellow, when you tap it, about 50% of the cases, if not higher, patients with TB with HIV, when you tap them, they'll be AFP positive. Why am I telling you that? Here's the story. Dr. Barber, what did you make us all say in National Jewish when we got up? More bugs, more drugs. And I think he's right. And this is what we've been going around saying. In HIV positives, it's a different disease. When they get extrapulmonary disease, they have more bugs, so you may even need more drugs or better penetration.
Because they have more mutants.
That's right.
You're dealing with the mutants. The more bugs you're out there, the more likely you have mutants.
And that, I think, is one of the differences in these cases. Now, you're going to argue with me, and I think they're going to be right. Look at that first case. He actually got resistant disease in his lung, but
Selection.
The bottom line comes down to is that not only, first of all, they have more organisms in these extrapulmonary sites. Well, they get more extrapulmonary sites. They have more organisms in them. And then lastly, what is the penetration of drugs into these extrapulmonary sites? And I think Jerry would be very quick to say, we're not 100% sure. So we know very well what penetration of the drugs are on things like lungs, but when you start getting into other areas, it becomes much more difficult. We know we're pretty good in the CNS also. So what the question we have is it possible, because when the TBTC went back and looked at 23 when we presented our data to them, they agreed most of the cases also had extrapulmonary disease. So maybe one of the factors is the CD4, and the reason I'm bringing this up is I want you to start thinking about these cases are different. And to get back to what Mark's original question was, we may need to do different things, but these cases are different, So we've always asked about the possibility that maybe that there's more organisms in these extrapulmonary sites, or maybe they're quote-unquote protected sites. That maybe one drug gets in and not another. And as we know, the same way that could be terrible if your patient takes one drug without the other, how bad would it be if you have a lot of organisms in an extrapulmonary site and only one drug penetrates? And those are the kind of questions I think that need to be answered. So what we did here, and I know we're running out of time, so I want to do it really quick. So at AG Holley, we've been doing drug levels for a long time. As a matter of fact, we're told that as a state, we do more drug levels than any other state, and again, our support to National Jewish. But the bottom line is, we did a study looking over 2 years. We had 236 patients. We had 116 that we did drug levels on. And one of the things I really would like to show you that, 30% of our patients were HIV positive, other risk factors, GI disease. And we did a subpopulation of 64 patients. It was 256 drug levels for INH, rifampin, PZA, and ethambutol. And the bottom line, which I'd really like to show you, right, is that when you look at drugs like INH, 59% of all of our patients had lower than expected drug levels. Rifampin, 73% lower than expected. PZA, and this is what I was saying to you before, almost nobody ever has lower than expected. So that's why PZA, as far as a marker, is a great marker to see if somebody takes that drug. And ethambutol, 41%. And overall, 45% of all patients, right, had lower than expected levels. So what am I telling you? The finding in and of itself of lower than expected levels, I'm not so sure if that's significant, because all these patients got better. And we know if you went out there and tested all patients, probably a lot of them have lower than expected levels. But one of the things I think that's very, very important, and I think I got it here, was that the issue is that, I got it here, when you look at if you look at something like, I want to go INH, if you look at what percentage of these patients have really low, meaning less than 50% of expected, over 50% of all INH patients have really low levels, and then rifampin. And you can see here, right, over 70% of patients, and look at this, 14 of a total of 47, meaning, and these are, remember, all comers, 33% of all patients have lower than 25% of expected. And again, this really may become an issue when you have patients who are really, really immunosuppressed. And I want to go. So what we did is, real quickly, is that, so we wanted to now say, hey, look, so if you look in 1998 to 2001, before those recommendations came out, we wanted to study our experience with acquired rifampin resistance, and we had actually 6 cases of rifampin monoresistance. All were HIV positive. There was no rifampin monoresistance among HIV negatives. Notice all of them had a CD4 count. Again, that is shouting out. That is the key, less than 37. All had evidence of extrapulmonary disease on relapse. So some of them may have had it before. We just never checked, 80% had evidence, I want to bring this up, of non-adherence. And again, on top of everything else, I think there's a non-adherence issue. And here's the key. None were treated with highly intermittent therapy during the first 2 months. And 4 of the 6 were treated with daily throughout with rifampin rifabutin, which again suggests to me that the intermittency may not be the big issue here. And then what we wanted to do, we went back now and we said, hey, look, we now have switched to 3 times a week in daily regimens. Have we seen any difference? So we did another study looking at acquired rifampin resistance from 2004 to 2005. We looked at 356 patients. Almost all, 95% were treated with daily or 3 times a week, and we did not observe any acquired rifampin monoresistance. We were really happy. We were about to present this data and publish it. And right when we were about to publish it, we got these 2 cases. So I think the key comes down to, as we've talked about, is what does this all mean? And I think what it all means, in my opinion, is so what? That's what people ask me, so what? Why do you care? And I think the reason I care is that I think we're now allocating a lot of DOT resources that are precious towards something that we may not really make a difference. And that what we really need is more studies to find out what's happening, including, Mark, I think you may be right. I don't know the answer. Maybe these patients do need drug levels. And even if you get the drug levels, what are you going to do? I don't know. So I'm not here to give you any answers. I don't know the answers. What I'm here to suggest is, that after those 2002 MMWRs, as you saw, most TB patients switched to less intermittent regimens. And I think the recommendations place a potentially greater demand for DOT, but no studies since have shown that the recommendations have been effective in reducing or halting acquired rifampin monoresistance. Matter of fact, during our last conference that we had 2 weeks ago, well, let's not go there because I think we're going to go there right now. Sorry about that. So let's ask this question. All right. So the question is, are you aware out there of any further cases of acquired rifampin monoresistance in your program since the recommendations were suggested? And while you guys are answering that, anybody here know in their program or anything? And I guess I'm asking, but what we got the last time was something very, very interesting. And we had individuals from California and New York, and it was very, very interesting. What we found was there was cases that they found. Again, not amazing, but they were still seeing cases. And then this answer, which you all see, which I totally agree with, I don't know. And that's concerning to me. I think we need to know. We're allocating all of these resources, and I think we know, and I agree with you. That is kind of what we found, So, I'm sorry. Oh. No, wrong one. Sorry about that. I think, okay. So, what next? So, what we were proposing, and that's what I'm going to present to you, I think further studies are needed to answer this very important question that has implications for patient care as well as utilization of public health resources. Has the incidence of rifampin monoresistance changed since the suggested changes we're implementing? Is there a group that needs further interventions, meaning CD4 count? Does dosing schedule really make a difference, daily versus intermittent? Does pharmacokinetics play a role, and if so, how much? I think that, Mark, I really do believe. I think that's a really important thing. And do we need drugs with better half-lives or better penetration or better steroids like quinolones? Will that make a difference, especially in these very, very, very immunosuppressed groups that have a different disease? So that was kind of what this presentation was about, was really to kind of make you aware of what, at least what our experience is in these 2 cases we got. So what I'd really like to do now is, I know I went for a long time, is open it up to any comments or questions you may have. I really like to hear it, and again, I wish I had some answers. I don't. So, hey, Sue, you have a comment, and then we'll go to the phones in a second.
Yes, in exploring variables that might make a contribution to influencing these rifampin resistance, they're looking a lot into the genetic phenomes and how that alters the susceptibility to certain aspects of the disease. And, if we can't find anything, that might be an area where it could explain why some people are becoming resistant, not, including, we already know, we've seen some of these patients like from, with like more of a Native American type of background, the Central Americans, that they've developed pulmonary tuberculosis, even being HIV negative, and no obvious immunosuppressive conditions, yet they have some sort of genetic predisposition to develop these extrapulmonary types.
Spoken from the words of a psychiatrist. Dr. Zapata, are you not impressed with that? Huh? That's impressive right there.
But he may be right.
Oh, without a doubt.
Without a doubt.
Without a doubt. Whatever he says, he's right. Don't you know that? Never tell your psychiatrist they're wrong. Okay,
right.
First of all, I just want to emphasize that point. It doesn't go over well. The next thing you know, they're Baker acting you and stuff. But
but your questions have really created the reason that TB is still so interesting and why it's a wonderful research place for young academicians. There's so many neat questions out there with a limited population. Questions you brought up are just absolutely terrific.
And you know what the other beautiful part is that it's a reportable disease, which means that we're collecting data and collecting data and collecting data, and they all exist in these databases, and we have access to it now.
And if we play it right, there will be the resources to do the research, because both foundations and government need the answers.
The only problem with the research right now, I think you'd agree, is in the United States, luckily, TB is on the decline, and luckily, HIV is being treated earlier and more effectively, which means these cases are theoretically becoming less. But
not to worry, we'll figure out some new crisis by which we can recreate it. Every 20 years, it comes back.
Right.
Remember Reichman and his, the U-shaped curve of concern? Right. Absolutely, it's going to come back.
But and the bottom line, I totally agree with you, and I was just getting at is the point is that I think the only way we can tackle this is on a nationwide basis. See, if we all pull together as a nation, we'd have enough cases to really look at that. And that's what this really was. It was a call to arms to say, hey, look, we should be looking at, first of all, the CDC database to see if there is really a decrease in the number of acquired rifampin resistance. That's something that can be done relatively rapidly. Granted, it would be dirty, as you know, in the sense that there's a lot of different factors going on in the community. I believe the increased use of antiretrovirals, you're going to see a decrease in number of HIV-TB cases in and of itself, let alone antiretrovirals. But still, it's something where we can go and look at,
And as soon as you say it, somebody's going to disagree, and they're going to do more research, and the controversy will go on, and that's great.
But I think this is a question, not only does it affect the patients, obviously, because we never want to give somebody acquired rifampin resistance, but it affects the programs, it affects money and funding. And we were asked a question before that we didn't get a chance to answer. I really feel bad about it because my computer froze up. But they asked the question, if you're going to provide more DOT, like we're saying, or how do you continue, what would you cut out? And really what the question was getting at is, as funding goes down, it becomes more of a burden on us, or more of a responsibility for us to determine what works and what doesn't, and then make sure we invest in those that work. But we got to be sure what works, and we got to really look at what we're really. I think that's where the Cochrane report comes out. But what we are recommending, we got to make sure truly is worth the investment we're about to put in.
But don't forget the Institute of Medicine's recommendations.
Right.
The things that you can cut out are the things that you can regionalize. If you can use one doc for a larger region by using electronics, use the one doc. If you can use one central lab, use the central lab. It's the regionalization and cooperation between the states and the cities that allows you to then be most cost efficient. And the issue is going to get down to what is the cost per unit of service. Maximize your units of service, your cost goes down.
And those are the tough questions, I think. And I want to say that the CDC, I really got to give them a lot of credit. They're really trying to look at this right now. But this is just another issue that, just to point out something that we do every day, make sure that we know if we're doing it is correct. Do we have any, I've been talking. I really would like to go to the phones. Is there any questions on the line? I'd really, really appreciate it. It's always nice to hear from you. So is there somebody on the line that has a question?
Remember, if you would like to ask a question, you can unmute by pressing *7.
Any comments on the line? Not only just questions, but I'd like to kind of hear from you guys out there if you agree, disagree, or what would you suggest? Oh, there's somebody. What do you got to say? All right. Denise Yakalabi, I think you have a question? What color, what band is that? The red band. Go ahead.
The question stems on the two presentations that you had. With the survey that we have, I noticed that these two cases, were based on the social report, were also, the monoresistance probably stem from the lesion in the lungs. Then the question is, if we're talking about a low CD4 count, which probably might have facilitated, focus of the population of TB somewhere outside the lungs. These two cases, however, came back as positive from the lungs. And we saw that when we did the pogilotype, also confirmed that. So probably narrowing the concept that the acquired monoresistance was probably, extrapulmonary cases of tuberculosis. Now the question would be, could the alveolar macrophages and other things be partly contributing to this monoresistance in the lungs?
I think it's a great question, and Demetria, like everything else we're saying today, I'm not so sure the answer, and I think it's a great question. One of the things that interests me in both of these cases, and something, again, I'm really want to say I'm really biased, but both of these cases had adenopathy in the lungs, especially the first case, remember, they had both the adenopathy. And again, I wonder if what the role of adenopathy is. I question very strongly what the penetration is and how well it gets in. I don't know the answers to these things. I think these are all things that need to be answered. And to really echo Dr. Sabarbara's comment that's why TB is a great field, in the sense that there's a lot of things that still need to be done. And remember, this is a disease that affects the world. And to further what I was saying before, there's an obligation in the United States to run these trials. And the reason is for two things. First of all, right or wrong, the United States only believes data that came from the United States. And that's what it is. I'm not saying it's correct. The second thing is that we have the resources to do these kind of things, and we have an obligation, because if we don't do it, it's not going to be done elsewhere. And I'm really, really concerned that as we start treating more and more patients worldwide with antiretrovirals, and don't get me wrong, what a fantastic thing that we're giving more and more antiretrovirals to the world. But the problem is, what is the implications of giving these antiretrovirals with the TB meds without knowing what we're doing? And that's the question. And especially if we're resource poor here, imagine how resource poor we are in the rest of the world. Can the world do daily DOT? Can the world, those are scary questions. And what I just know is that we keep putting these drugs into the community with these antiretrovirals and not knowing what we're doing. Remember, the world is really, really small. So what we're doing in one place will affect us. And I think that's where the implications come down to. I think we have the obligation to do these. It's just a will. It's a political will. You just got to do it. And that's what we're trying to, point out. All right. I'm going to make one last statement. Is there any other calls or any other comments on the line? If not, I'm being told no. I want to thank each and every one of you for joining us today. We look forward to seeing you guys back in 3 months, and we'll be doing more M&Ms. And again, thank you so much for your participation, and we'll see you real soon. Thanks again.